right, welcome everybody. Today's episode of the Friday Chalk Talk. Today, I am happy to be presenting Dr. Natsu Fukui and Dr. Sarah Wortingham, both physicians at the Center for Palliative Medicine at the Mayo Clinic in Phoenix, Arizona. Dr. Fukui did her training at Dartmouth and Northern Virginia Fairfax before her palliative care fellowship at Mount Sinai in 2019. Since then, she has been working in Phoenix, Arizona, and is now also the fellowship program director. Dr. Wortingham attended the Medical College of Wisconsin. She completed her transitional here at St. Luke's and subsequently completed internal medicine training at Banner Good Samaritan Medical Center before specializing in hospice and palliative medicine. She completed fellowship training at Mayo Clinic in Arizona, and she is also now the assistant professor in the College of Medicine. Her practice focuses on the supportive care of patients with life-limiting illnesses in the inpatient, outpatient, and hospice settings. We are so grateful to have you both here today and so excited for our topic, are opioids contraindicated for the palliative care patient with hypotension? All right, so can you describe a particular case or scenario that could help set up what we will be discussing today?
Yeah, so thank you, Jessalyn, for the introduction. I wanted to start by sharing a case with you that we described in our paper. So our patient was a 77-year-old woman with end-stage renal disease who was on hemodialysis, and she was admitted to our hospital with altered mental status. Unfortunately, she had a very long hospital course with multiple complications, including recurrent ascites, peritonitis, and bacteremia. And one thing that specifically worried the teams that were caring for her was that she had recurrent hypotension. And so, of course, this made it very difficult for her to tolerate her regular dialysis sessions. And many interventions were tried, including midodrine, hydrocortisone, and fluorocortisone, but she continued to have pretty soft blood pressures. Additionally, towards the end of her hospital course, she started to develop severe pain in the lower extremities. And after some workup, she was diagnosed with calciphylaxis. So calciphylaxis is a condition that we see more commonly in patients with end-stage renal disease, and it's characterized by severe, painful ischemia and necrosis of the skin. And unfortunately, there really are no effective treatment options. So it's usually associated with very high morbidity and mortality. So in this setting, the internal medicine team decided to place an order for oxycodone immediate release, 5 milligrams every 4 hours as needed for pain. And I think most of us here would agree that this is a pretty standard starting dose for an opioid-naive patient and a pretty common order that we see for patients in the hospital. But despite that, the nursing staff who were caring for her expressed a lot of concerns about administering this medication to her. And specifically, they were worried that the oxycodone may further lower her blood pressures. And as her pain worsened and it became pretty clear that 5 milligrams of oxycodone was going to be inadequate to manage her pain, the physicians also started to become alarmed. And so the hospitalists and the nephrologists sat down with the patient and family and discussed with them two pathways for care moving forward. One being continuing with the disease-directed therapies, including the dialysis, but with the understanding that she was continuing to suffer with a lot of pain, or to transition to comfort care with aggressive symptom control, with understanding that she may have worse hypotension and that may actually end up hastening her death. And these two options were basically presented to them as exclusive options. And as you can imagine, the patient and family were quite alarmed. So at this point, the palliative care team was called for help. Okay, next slide, please. So as with any consult, our team started by trying to explore the patient's understanding of her illness and tried to meet the patient and family where they are. So the patient and family shared with us that they actually had a pretty good understanding of the serious nature of her medical problems and an understanding that she was probably going to die at the end of this hospital course. They also shared that prior to this hospitalization, the patient had actually been quite active and independent. She was driving herself to dialysis, living alone, really enjoying life. So it was really hard for them to suddenly wrap their minds around the fact that she was now dying. Our team also spent a lot of time listening to the people who were calling us, the physicians and nurses who were caring for her. And they expressed a lot of emotional distress around this whole situation because it was so hard for them to see this frail, older patient in so much pain. And they were also worried about giving her medications that might hasten her death. And so, with all this in mind, our team tried different interventions to try to alleviate her pain, including scheduling her acetaminophen and then collaborating with the compound pharmacy to try topical morphine cream. But despite that, she continues to be in a lot of pain. And eventually, we decided to cautiously start IV hydromorphone as needed and slowly titrate up the doses. Unfortunately, though, one day during what ended up being her last dialysis session, her systolic blood pressure dropped all the way down to the 40s, and she was crying out in pain and became unresponsive. And from what I've heard from the staff that was at the bedside, this is really a very traumatic event for the people who were caring for her. So at this point, there was a rapid goals of care discussion, and the family and the medical teams all agreed that it was time to transition to comfort care, and the patient died peacefully in our hospital. So next slide, please.
All right. And then, so that's a very interesting topic and good inspiration. What results did you find as you were researching and looking into this topic for you?
Yeah. So we were very interested in exploring the literature to see if there was any evidence or any information that could guide us in talking about opioids and their hemodynamic effects. And we did find a bunch of studies, but we found a handful that we thought were interesting and informative that we described in our paper. And today I just wanted to highlight two of those studies. The first one that I have up here is a pretty old study from the 1980s. And this was a study by a group of anesthesiologists from Mass General. And the authors here were really interested in an hypothesis that maybe there was a difference between morphine and fentanyl and their effects on hemodynamics because of the difference in histamine release. So they selected 15 patients who were scheduled to undergo CABG, and they randomly assigned these patients to receive a morphine infusion or fentanyl infusion. And in the paper, they specifically mentioned that the doses that they chose were pretty standard doses for patients who are going into the operating room. And they monitored their hemodynamics using a pulmonary artery catheter, as well as blood samples to look at histamine levels at 5 points during their therapy. And what they found was that among the patients who received morphine, there was a very wide range in responses. But on average, there was a 750% peak increase in histamine level and a significant decrease in mean arterial pressure. And there was a good correlation between histamine levels and blood pressure, or MAP. They did not see this kind of pattern among the patients who received fentanyl. Okay, next slide, please. And the other study I wanted to share is a more recent one, which is done by a group of researchers in Canada. And this was a retrospective cohort study where they reviewed more than 8,000 charts of patients who had received critical care transport. And they specifically looked at the cases where patients received opioids or sedatives and looked at the incidence of post-medication hypotension, which in this study they defined as a systolic blood pressure of less than 80 or a MAP of less than 60 or need for vasopressors within 10 minutes of medication administration. And what they found was that hypotension was observed in 1.9% of the patients who had received IV fentanyl and 2.3% of the patients who had received morphine. And there was a significant association between the dose of morphine and the incidence of post-medication hypotension. Now, they also found that new hypotension that was deemed to be temporarily unrelated to medication administration was actually 5 times more common than post-medication hypotension. And there were many other factors that seemed to be correlated, like baseline hemodynamic instability and longer transport times. Okay, next slide, please.
So in doing this research, what were some limitations and also to this paper and maybe some potential areas for future research?
Yeah. So while we found these handful of studies to be interesting and informative, we didn't really feel that they were practice changing for the work that we do in palliative care. Most of these studies were really old and they were very small in scale. Some of the studies were animal studies or international studies where they used different opioids that we don't have available here in the United States. Also, all the studies were done by disciplines that were not palliative care, like anesthesia and emergency medicine. And as we all know, in palliative care, we take care of patients under such unique circumstances. So we felt like there were many remaining questions that came up. Do certain opioids have greater effects on blood pressure than others? It seemed like maybe morphine has more of an effect than fentanyl. But what about formulations and the way we administer medications? Like, is there a difference between IV boluses of opioids versus IV infusions, or IV versus PO, or what about PO extended release versus PO immediate release? We also wondered if we have to worry as much about hypotension in patients who are on long-term opioids, like the patients we care for in our palliative care clinic, who we know have been tolerating opioids for many months or years safely. Do we need to worry about opioids causing hypotension in those patients? And more recently, I think within medicine, but also especially at Mayo Clinic, there's a big interest and excitement around pharmacogenomics. And we wondered if is there a role for pharmacogenomics in individualized medicine when we're thinking about opioids and their hemodynamic effects? Okay, next slide, please.
All right, that I agree that is all very good food for thought going forward. But and how can we take this information that we have from your paper and use these results in our practice in palliative care?
Thanks, Jocelyn. And thanks, Dr. Fukui. Good morning, everybody. I think Dr. Fukui maybe already gave sort of the final answer, which was, I don't know if anything we read was practice changing for us. I think that we're really good at managing opioids, all of us who do palliative care every day. And I think one of the main messages that we need to drive home is not missing the forest for the trees. There's 2 anecdotes I want to share before we dive into that. And I was just thinking of these as Dr. Fukui was talking. But the first was just to share, I've given Narcan exactly 1 time since I completed my training in hospice and palliative. And it was after a dose of 5 milligrams of oxycodone, which is embarrassing, but it's a true story because a patient acutely decompensated. And of course, the family was extremely worried about opioids. And it had taken me, days and days to convince them of this. And then they acutely decompensated, an hour after I gave 5 milligrams of oxycodone. And then the other anecdote that comes to mind is when I was in fellowship and I was rounding with our ICU team, and a patient had just transitioned to comfort care, and the ICU attending said, okay, well, now this patient gets 5 milligrams of morphine, IV every 2 hours PRN. And I was like, how did she come up with 5? And I asked her and she said, that's what everyone gets. And so I think we still face a lot of barriers to opioids. And I think we always have to be advocates for our patients and for the safe and appropriate prescribing of these medications. So next slide, please, Jessalyn. just like we do with our patients, I really like to think in that zoomed out fashion. So what are we going to take home from this? There will never be enough of us to take care of every patient who needs opioids in the hospital. Just in the last 10 years, I think we've seen such a shift with how people are talking about and managing opioids, and even more opiophobia than we did, say, 10 years ago. But we have to continue to allow our colleagues in hospital medicine or oncology to safely and appropriately prescribe these medications and feel comfortable doing so. Whenever I'm working with our fellows, I'm talking about how I can't be the only person in the hospital who's comfortable prescribing opioids because there's just not enough of us. This is something that you guys are all familiar with from Dr. Timothy Quill, but we need to make sure that every patient has good access to pain and symptom management, good management of their depression and anxiety, and that our colleagues who are not subspecialty trained can have good conversations about prognosis, treatment, and all of those things. And then we're there to really do that subspecialty management of advanced pain and other symptoms. Jessalyn, next slide, please. I'm preaching to the choir here, but these are the NCCN guidelines about the management of pain in our cancer patients. But it's very clear in the guidelines that severe uncontrolled pain is a medical emergency. We're talking about cancer patients here and should be addressed promptly. I don't know what it's like for you guys in your practices, but I just don't see this addressed in this way here. I say that uncontrolled cancer pain is my ST elevation MI. When I get that call from the nurse, I'm going to be at the bedside as quickly as I can, following the guidelines to get their pain down. And really, it shouldn't take me more than 3 doses of anything, spaced out every 15 minutes, if need be, to get control of someone's pain. We shouldn't have a cancer patient in the hospital who's suffering for hours on end or days on end, or, even worse than that. So, Jessalyn, you started by asking the question, what do we take home from this? For me, I took home from this that I have such a strong continued role in advocating for my patients on that sort of one-on-one bedside basis, but also, that role that I think so many of us in palliative care feel towards education, and that we need to be, presenting at grand rounds more and having more and more residents and medical students rotate with us so that we can make sure that people aren't afraid to give these safe and appropriate medications. Next slide, please. And then I think Dr. Fukui and I would love to just start a dialogue and hear a little bit more about the practices that you guys are in. And so the first question would just be to ask, what scenarios have you guys encountered related to hypotension and opioids?
Yeah, I guess I'll look for some hands up too, but I guess I can start. I worked in an ICU before this. Oh, I see Marty's, I got you. I worked in an ICU before this, so this would come up regularly. Can we do this or can we not? Or do we need to shift focus before we can appropriately treat their pain, exactly as your case had described? So it's very interesting, but I agree with you. It's not necessarily immediately practice changing, but something that start the education, start the conversation.
So if I can press you a little bit, so much in palliative care doesn't have randomized controlled trials, and we just don't know definitively what the right answers are. And we have to work with what evidence we do have, or maybe it's experience that we do have. And so even if this has not changed your practice, how do you talk to patients who are struggling with low blood pressure and are having a lot of pain, and you're having that risk-benefit conversation? Do you have certain terminology or phraseology or elevator speech that you use when you're giving that pitch or educating them with as much as we think we know?
I'm happy to answer, and then I'll see if Dr. Fukui wants to add to that as well. I certainly have an elevator pitch about opioids, and I almost started to give it to you guys when I was talking just a minute ago, which is, I think these are safe, appropriate medications. They've been around a long time, and I have no concerns about using them to help manage your pain. Or, if there was some sort of extremely odd situation, I could temper that a little bit and say, I have very low concerns, and, I'm going to be here every step of the way to make sure that we're finding that balance between managing your pain and not giving you any other issues or side effects. For me, it's not the hypotension where I get really caught. Sometimes using opioids, it's a patient where their respiratory status might be really compromised, and they're, already maxed out on high flow, but not quite ready for that hospice talk. I feel like that's where I feel a little bit more stuck. And otherwise, it's just doing a lot of education, especially with, as Jessalyn said, with our nursing colleagues, and making sure that they feel comfortable, right? It's one thing if the patient feels comfortable, but I need to make sure the nurse feels comfortable too, in their own prescribing, and because that's going to reflect to the patient. And also, I've asked nurses to, make sure you talk to the night nurse, and if that person's uncomfortable, they're welcome to call me too. But making sure everybody sort of along the chain is comfortable. Dr. Fukui, I don't know if you have anything to add to that.
No, I think I do the same. And I think, as always in palliative care, it's helpful to talk about like what it will do that's going to be helpful and emphasize that, because I think we kind of tend to believe that the benefits are larger than the risks, and that's why we're prescribing these medications. So really to emphasize the benefits and how we think it's more helpful than harmful.
I ask because, just very recently I've had a case, and I've had handfuls of these throughout my career, but just very recently where I pulled out your paper and I reread it before I went to go talk to the family, because this patient came into the hospital in pain crisis, had really advanced cancer, probably months left to live, and the primary team had withheld all of their chronic opiates because they were also having some hypotension, and they were fearful, this patient, that they would harm him, that they would kill him because of that. And yeah, we don't have all the answers, but I still talked about some of the things that you brought up, that there's some evidence that suggests that opioids could lower blood pressure. So there's some potential risk. I don't know how much that risk is. I think that it is low, but it's a risk benefit, and what's more important to you. And we can make sure that you are comfortable and your pain is well treated, understanding that there is some risk that you're taking, but what do you value more? And educating the staff and the medical teams about what it is that is most important to that patient, so that you're right, they don't feel so fearful about what they are doing. Even if we don't know the exact answer, just talking about the uncertainty.
I see some discussion in the chat that's quite interesting too. Rachel had made a point that, when opioids are given on hospice, we're comfortable with that because then we're not worried about the hypotension. We're treating the patient, not the numbers, right? We're looking at it from a symptom standpoint. But then Maureen brought up a good point that where the sticking point and the trouble really is that conversation or that perception that we can't appropriately treat your pain unless you choose hospice. And that kind of makes it feel pushy, that the only way you can ever really be comfortable again is if you're willing to accept it's the end of your life, and people just aren't always there when this is happening. So this could potentially provide a middle ground, but I think it's a starting point and a lot of education to get there.
Yeah, I agree. And I think in some ways that was the situation in our case as well. And I think I often kind of help or talk to the clinicians to say, it's okay. It's okay if it's not so black and white. And there's kind of the middle ground, and to try to do both as best as we can.
And when there's a talk I give every year, it's next month, so it's on front of mind right now, but it's to a very large audience of APP providers. And it's one of my favorite places to present every year. They're a little more welcoming than the physician audiences, I find. But, it's non-palliative care providers. And I asked them to do a reflection exercise to, sit there in a room with a couple hundred people and close their eyes and imagine that their loved one is in the hospital. They've had a new cancer diagnosis, and the hospitalist just gave them 1 milligram of IV Dilaudid. Their loved one is in excruciating pain and is told, I can't give you any more pain medicines because you've already had too much. That's just not a place any of us would ever want to be. And so we just have to make sure that we continue to advocate for the safe and appropriate use of these medications because, as I've, said several times now, they can be used safely. And, something I've done very rarely in my practice is to, use these bitty baby doses of things. It often comes up with Ativan where I really need to give someone Ativan and I give like 0.125 milligrams IV and, some pharmacist somewhere is laughing at me. But if that's how I can build trust with the patient and the family and the rest of the team and get a little bit of symptom control, then that's what we can do. And we can, do the same thing with opioids too.
Yeah, exactly. And Steve had even said your advice about educating the chain, starting with the patient and family, but the nurses have to be comfortable giving it. The other providers on the team, including the attending, have to be understanding that we're not trying to cause harm, we're trying to help and find that balance. So I think it really goes from bedside all the way up to make sure we're on the same point and building trust. And I think that's really important. So I guess unless we have more on that topic, I'll kind of open it up to see if anybody else has any other questions or comments for Drs. Fukui or Wortingham.
I will ask, Sarah, do you really think that acute decompensation after 5 milligrams was really due to that 5 milligram dose? That seems like such a baby starting dose.
I almost forgot to unmute myself. No, I don't. And it's like an embarrassing story to tell, but we have to be honest. And
Sure.
luckily, this was earlier on in my career than now, so I can giggle about it. But, what are you going to do? I didn't think there was much harm with giving the Narcan, and you've got family members very distressed at the bedside. You have a distressed nurse. No, I knew it wasn't, or at least I felt strongly that it wasn't this baby dose of oxycodone that caused someone to decompensate. But I think the better part of valor was doing the Narcan at that point.
Mm-hmm. I feel like that's a common thing that we see, like, what's the cause? Blame the opioid, right? Even though it was just coincidental. There's one question in the chat, and then Steve has his hand up. In hypotensive situations, do you generally rotate to fentanyl, and how do nursing units respond to this?
Yeah, I do not do that as a routine practice. And especially, I think in our patient population, we know that most of the time the pain they're experiencing is not going to go away, because we don't have a great treatment for their underlying illness. And so to me, it doesn't make a whole lot of sense to utilize a really short acting opioid like fentanyl. For example, in this patient situation, I guess we could have considered that with some of the data we have, but I don't think that IV fentanyl would have been very helpful in, for example, if she was getting wound care or something that took a lot of time because she had such a bad wound situation. So that is not something I generally do, although I will say I have done it once when the team was really, really, really worried about hypotension and the goals are still kind of like in flux. And so I said, okay, well, you know what? Let's just do IV fentanyl. We all know it's short acting, and if it causes hypotension, we can stop. So I have done it once, but I don't do it as a general practice.
And then Steve, and then I don't see any more, so we'll probably wrap it up after that.
Yeah, Dr. Wortingham in particular, I really liked what your example that you talked about with the APP education. And I've noticed that it does seem like there are a lot of physicians who practice, either are hospitalists or critical care doctors, who really have fixed beliefs about how they're going to practice. And the older they are, it's a little bit more difficult to convince them to change their practices. So I'm wondering, just to give us hope, have you been able to influence practice change among other physician groups?
Well, thanks for the question. I stand on my soapbox a lot. At Mayo, we have a lot of opportunity to give CME talks. And, I have one slide that, I hope someday to take out of my slide deck, but, it talks about how we talk about these medications and are we calling things opioids or narcotics? And, I will continue to stand on that soapbox for a long time. I would say I'm better at influencing APPs, maybe because they're better at learning. I don't know if I can say that, but are more open to it than these some of our physician colleagues. have I been able to influence physicians? Certainly, not en masse, but one-on-one. I've been able to build some rapport and change people's perceptions. I think that's been most prominent with our cardiology and CT surgery colleagues, who we've really built our relationship with them over the last decade. And it's a little bit longer story, but the first patient they asked me to see who was pre-LVAD, I was still in fellowship. I wrote my opioid recommendations, and the next day they asked me to sign off the case. But now, we're involved in all of those patients' care, and they look to us to be allies in managing symptoms. So I think that's where we've made some of the most progress. Maybe the least progress is with some of our hematology colleagues. But I think that's supported with the data too, right? Those patients have a hard time getting to hospice. And so we try every day and make progress, and still working on it.
Thanks.
Thank you so much for this topic, this discussion. It's absolutely great and totally relates to practice. We really appreciate all of your time in coordinating this and with speaking with us today and answering our questions so patiently. So thank you so much.
Thank you guys so much for having us.
Yeah, and thank you for the discussion.
Of course. I hope everyone has a great Friday and a great weekend.